Hello and welcome back to What Now on the threshold of life, death, and grief. And I'm here recording with my friends and colleagues today.
David Kennedy.
And Red Keating.
And I'm Julie Brown. And today we have a very special guest, Dr. Harvey Max Chochinov, who we are so excited and looking forward to a conversation. Welcome, Harvey.
Thank you. I feel welcome.
I'm going to do the official thing and read your bio just to get us started, and then we'll jump into some conversation. So Dr. Harvey Max Chochinov is a distinguished professor of psychiatry at the University of Manitoba and a senior scientist at Cancer Care Manitoba Research Institute. His research in palliative care has resulted in more than 350 career publications, broaching diverse topics such as depression, quality of life, suicide, vulnerability, spirituality, and existential distress. He has also led a large program of research on dignity within the healthcare setting, which includes the development and study of dignity therapy. He is the co-founder of the Canadian Virtual Hospice, co-editor of the Handbook of Psychiatry and Palliative Medicine by the Oxford University Press. His latest book is entitled Dignity in Care, The Human Side of Medicine, published by Oxford University Press. He is also an officer in the Order of Canada and an inductee into the Canadian Medical Hall of Fame. Welcome.
Thank you.
Whenever we have guests and Julia read their bio, I'm always wondering, with such a rich bio, what do you do in your spare time? But we are here to talk about dignity therapy, Harvey, and I guess we could just sort of start by asking you sort of how did you come to this work? And maybe for our listeners who aren't familiar with dignity therapy, if you could give us an understanding of what that is.
Sure. Well, I guess I came to this work by way of, my background is I'm a psychiatrist. I studied psychiatry here in Winnipeg at the University of Manitoba, became interested in the interface between psychiatry and cancer, for the most part. That led me to doing a fellowship at Memorial Sloan Kettering Cancer Center back in the late 1980s, and then came back to Winnipeg primarily to start doing clinical work, primarily with patients who were facing malignancies of various kinds and their families. And then after a few years, fell into the whole area of research, which is not something that I'd really planned for my career, but I kind of got sort of bitten by that research bug and began doing a whole series of studies looking at, what I refer to as the experiential landscape of end of life. So things like depression and anxiety and hope and hopelessness, desire for death, will to live. Eventually, started to pay attention to what was happening in the Benelux countries who, this is decades before Carter and made legislation in Canada, became interested in what was happening in the Benelux countries where people were able to avail themselves of euthanasia or assisted suicide. And then there was a pivotal study by Paul Vandermas that came out in the late 90s. Paul Vandermas was a physician commissioned by the Dutch government to study what he referred to as MDEL, or medical decisions to end life. And to make a long story short, besides reporting the prevalence, that is the extent to which people were accessing this means of hastening their death, they also went to the physicians who were listed on the death record of those patients and asked these physicians, why did your patient walk this particular path? What led them to this decision? And it was according to these physicians that loss of dignity was more cited than any other reason as to why they sought out a hastened death. And so we thought, well, goodness, if dignity is worth dying for, then dignity is worth studying. And what we found in the literature that time is that there were no empirical studies of dignity in the terminally ill. No one had really looked at it in a meaningful way. Dignity was cited all over the literature in a way that it was used kind of as the trump card, so to speak, forgive the term. In other words, it was the penultimate, it was the argument that you would make if you I mean, if you were arguing for something, you'd say, like euthanasia-assisted suicide, you'd say, my body, my choice, my autonomy, this is a dignity issue. And in the opposite side of that political offense, if you were saying, I don't agree with this, then you'd say, the taking of human life, violation of Hippocratic oath, this is primarily a dignity issue. And we said, look, we don't come at this with a political axe to grind, and we're not the moral police, but we are clinicians who are interested in knowing, does dignity figure into understanding end of life experience? And that began a whole program of research, developing an empirical model of dignity in the terminally ill, developing a measure that we refer to as the patient dignity inventory based on that model. And then also based on that model, we said, well, if there's an intervention that might target dignity somehow, even though that sounds kind of vague and nebulous, clearly this model ought to provide us some guidance. And so we looked at the model and used it to inform what emerged as dignity therapy.
I think it's so important to recognize the reality that that coming to one's end of life is so much more than just a medical journey here. And we, the three of us have obviously committed our lives into that context of life is not just solved or dictated by medical procedures and terms. And nowhere is that more evident that as we come to the end of this life. So this is very, very important when you realize that it's our humanity that we are talking about and are dealing with. And it's such a broad term that doesn't get recognized often.
And for your listeners who may not be familiar with dignity therapy, it is a legacy-based intervention, or we refer to it as a generativity. In other words, it provides patients an opportunity to extend their influence and to extend the memory of who they were into the next generation and the generations thereafter. In other words, it provides a way of them being able to give voice to things that will even transcend the event of their death. These conversations are usually focused on some biographical issues that they feel are pivotal for people to understand who they were and what they were about. It will also include critical pieces of wisdom that they might want to share, or hopes or memories that they might want to pass along. Even guidance for the people that will soon be mourning their loss. Those conversations are guided by a trained therapist. They are transcribed verbatim. They are then edited according to a particular protocol that we have worked out, and in quick order, because there is this kind of ethos of immediacy. What you say matters. It is then edited and returned to them quickly so that they can then share it with their family members and the people in their lives that they would want to have access to this document that can, as I say, then have kind of a life of its own that will even transcend the event of their own death. So in essence, that is dignity therapy. At this point, it probably is the most studied psychological intervention in palliative care. There are about 100 papers collectively in the literature and about 12 systematic reviews that collectively point to the ways in which dignity therapy can enhance end-of-life experience.
Throughout your book, Dignity Therapy, Final Words for Final Days, Harvey, you give many, many, many case examples. We get to know some of the patients that have worked through dignity therapy. Are there a few that come to your mind, just so for our listeners, we can kind of give them an idea of what this might sound or look like?
Since the book talks about cases that were top of mind, way back when I first wrote that, why don't I skip forward to, the last case of dignity therapy that I did fairly recently. This was a young woman in her early 30s, young marriage, young child, I think about a year to 18 months. And she heard about dignity therapy and immediately knew that this was something that she wanted to do. She had been diagnosed with an advanced breast malignancy. So this was stage 4 breast cancer. And she knew that her time remaining was going to be limited. And the reason that she was so keen on doing dignity therapy, as I recall her saying to me, is my child will not remember me. And I want to do something that will somehow extend the memory of who I was so that my child will have access to that. And so in the session that I conducted with her, I mean, dignity therapy usually consists of a first session where we kind of introduce it, we answer any questions, we do something that we call a framing interview, which means that we find out, basically, I mean, what are your goals in doing this? Who is this for? What are you setting out to accomplish? And framing provides kind of a nice metaphor. If you're thinking of painting, it's good to know, what is the frame of this picture we're about to create? Because in the absence of knowing that, you don't necessarily know how you're going to achieve what the patient has in mind. So we do a framing interview. And again, for her, it was, I need my child to know something of who I was. That was very clear. When we then sat down and went through the session, I mean, she recalled some pivotal events in her life. And again, dignity therapy isn't about creating this, very fulsome biography because, that's just not feasible to do in a limited amount of time. But you can pull out key memories or, key events that, help shape this person into who they were, or for them were kind of symbolic of, what they were about. And so she did that, and that is usually kind of the first half of dignity therapy, sort of the more biographical. And then the latter half tends to be, sort of the more emotionally evocative. So, what are the things that you would want to say, in your voice? What are the things that you would want to say, even if they've been said before, so that this will now be embedded within this document? She also talked about, giving thanks to her parents for bringing her into the world. She thanked her siblings. She also, of course, shared some critical pieces of wisdom, and they were sort of more like guideposts for her daughter that she might be able to kind of go back to them and look at them for some kind of guidance. And at the end, gave explicit permission to her husband to find a new partner, with the proviso that whoever he would choose would be somebody that would love her child the way that a mother is meant to love a child. So, to me, it was an extraordinary example of what dignity therapy can do, because, in the absence of that kind of intervention, it's very easy to feel kind of hopeless and overwhelmed, and the sadness can just kind of permeate unless and until, you have something that says, I know what we can do here. Yes. And together, we were able to create this kind of marvelous document that, since has been completed and returned to her, and, for her to be able to share with the people in her life that matter most. So there's a contemporary example of dignity therapy, and I think it very nicely illustrates the kinds of things that dignity therapy can do.
I'm listening to that thinking, wow, what grace and vulnerability that must have been for that person who you did the work with. And that a certain level of acceptance or giving over to the reality of my own death must be a criteria for this type of work. Is it?
I think it more in terms of what I've referred to as kind of existential readiness. And for some people, that comes at a time when they're, kind of facing down death, or death is feeling kind of like it's encroaching and very proximate. But for other people, death may seem, more distal. So, for example, we've done dignity therapy in, cohorts of frail elderly. These are people who don't have a specific diagnosis per se, but they're at a time in their life where the ability to look back, to reflect, to kind of see how all the threads kind of gather together in a way that kind of integrates them, is a wonderful opportunity. And in fact, over the 20 years since dignity therapy first made its way on the scene, its applications have expanded. I mean, originally it was intended for the imminently dying. That's how we kind of figured it would be used. And now we see it applied in various different ways. And the common denominator in terms of its application, dignity therapy is very much about, and this is another topic I'm sure that we're going to talk about, personhood. Mm-hmm. Dignity therapy is very much about eliciting personhood, about making sure that the individual with the ailment is, first and foremost in our minds, not talking about their illness per se, but who they are as individuals. And so wouldn't you know it, that dignity therapy has found its way into applications in other contexts where personhood is under assault.
Yes.
And sometimes that can be, it may be for the frail elderly. It may be for people who have an earlier stage diagnosis of a life-threatening or life-limiting illness. It's being applied in psychiatric populations where personhood or self is the organ under assault. I was sent some studies of dignity therapy as it's applied to people who are incarcerated, who will be living out their final days in prison. So again, liberty has been removed. And again, that's another instance where personhood is under assault. Oh, and I forgot to mention, there have been some studies that have also looked at dignity therapy in patients with mild to moderate dementia, but oftentimes done in instances where it will be done with the presence of a family member, so that it can become, to the extent that they require assistance, it becomes a co-creation of the patients and a person in their life who can help fill in some of the missing gaps.
What have you come up against in terms of systemic resistance to this approach?
I mean, dignity therapy is just one, and I would say is a narrow approach that has come out of this body of work. In other words, it's not as if dignity therapy is a panacea, and that in order to have a good death, you need to have dignity therapy, and everyone will want it and need it. It has applications in people who, whose dignity is undermined by kind of assaults on this notion of generativity. I don't feel like my life will have made a difference. And so here's a way of being able to say, well, it's not too late. Maybe there are things that you want to say or things that, you can articulate that will actually be helpful to the people you're about to leave behind. Some of the systemic resistances to that have been the time, the resources. You need to have people who are trained. Although, it's interesting, how these things kind of eventually, take hold. I mean, dignity therapy, the first paper probably came out about 20 years ago. And now there's probably not a day that goes by that I'm not getting a request from someone somewhere in the world saying, so where can I do the training? And when's the training available? So it's interesting that it seems to be, taking hold in a way that people now are training, and we offer, regular training for people in dignity therapy. I mean, before COVID, those were all in person, and post-COVID, it was put on hold. And now we annually do a 3 half-day virtual training seminars that are very well attended. There's also cost, and what's interesting around. Some of the cost issues are resolving because of advances in technology. So, at one time, who's going to pay a couple of $100 for the transcription, for example? And I always kind of smile when I talk about that or think about it, because if dignity therapy were not a psychosocial intervention, but if we were talking about a biological intervention, we say, look, we've got this new drug. Mm-hmm. There's about 100 papers in the literature. It looks like it's got really good impact across these various different outcome measures. There have been randomized controlled trials internationally. Oh, and by the way, it seems to have multi-generational impact. And someone said, geez, that sounds like a really important therapy. How much does it cost? And you say, well, $200. People would say, that's ridiculous. And what they would mean is you can't do anything for $200. Mm-hmm. But because we're talking about a psychosocial intervention, it was always this big hiccup, like, well, who's going to pay $200 for this transcription? And I think that really speaks to kind of, certain biases that are held against psychosocial interventions that are meant to be free, that they're not supposed to take up any resources whatsoever. But maybe I should get off that high horse for a moment. Technology has solved some of that. So, you can get, there are some really good programs now that can, give you a transcript of your conversation and save you those costs. There's still the time that it takes for editing. But, what I have found, and this has been reported by others who have done this for, enough time, people just get better at it. So, if you know how to elicit an interview that is more organized, then it is not as big a deal to try and edit it into a coherent document that then can, speak for the patient. So those are some of the resistances. In response, by the way, to some of that, what I've also tried to point out to people in healthcare is, not everybody needs dignity therapy, but everybody needs the essence of dignity, which has to do with affirmation of personhood. Yes. Every single patient that walks in the door, and this is not, by the way, just particular to palliative care, this is across the entirety of medicine. Everybody who crosses our threshold in medicine wants to be seen as a whole person. And the times that, you run into problems are when patients feel that they were treated just like another patient. Because what that means is they were treated in a way that was kind of generic, or at worst, a way that felt kind of emotionally assaultive or crass. And to do that kind of work, to put personhood and eliciting of dignity on the clinical radar, it doesn't take nearly as much time and resources as something like dignity therapy, but nevertheless, it does take people at least being mindful that this is a critical element of contemporary healthcare.
Mm-hmm. And Harvey, when you talk about this in terms of contemporary healthcare, you often reference one or two questions that the healthcare provider could be saying just to make sure that we're seeing someone's personhood. Do you want to speak to those questions?
I think what you're referring to probably then is the patient dignity question,
yes. Yeah.
Which is distinct from the patient dignity inventory. So
yes.
The patient dignity inventory is an inventory of 25 items. They're all modeled on the empirical model of dignity in the terminally ill. And it just allows you to administer that to a patient. It takes a matter of minutes for them to respond to say, which of these things are a problem for you? And it's very multidimensional. So, anything from, I'm in pain or I have depression to I no longer feel like I'm the person I once was. And I pause on that question because it is a profound existential issues for our patients. In fact, it was one of the questions that was most highly affiliated with sense of dignity in some of the studies that we did. So this sense that life, illness, adversity, it can start to kind of put cracks in the armor of our sense of who we are as people. And so if we can identify that, and now that we know that so many patients actually struggle with it, what it says to me is if we can identify it, it puts us in a better position to be able to respond to it. The other question, though, that I think you're referring to is the patient dignity question, which asks quite simply, what should I know about you as a person in order to take the best care of you possible? And the way in which we have studied that is to go to the bedside of the patient or the family, because it works equally well with a family informant if the patient can no longer speak on their behalf, to say, we know an awful lot about the medical condition. We know all of the things that are on your chart. But what we don't know very much about is who are you, as a human being? And therefore, the PDQ, what would you want us to know about you as a person? And that's the critical element, as a person in order to take the best care of you possible. that is meant to be the foundation of a brief conversation, 5 minutes, 10 minutes, 15 minutes at most, all centered on personhood, and another way of kind of stating it, because, I've had people say, well, gee, Harvey, I've tried that and the patient just didn't get it. So, well, they probably didn't get it because it kind of comes as a shock to people that, so you want to know about me? Mm-hmm. And it takes people sometimes a little while to wrap their minds around the idea that this is a different conversation. You're not asking about my tumor. You're not asking about my symptoms. You're asking about who I am. Mm-hmm. And so another way I sometimes, explain it to people is say, well, let's put it this way. If you get to choose the lenses, the glasses that everybody walking into this room is going to look through and see you, how would you like to shape those lenses? Less metaphorical, how would you like to be seen? And what you find is that patients in a very brief period of time tell you critical elements of who they are. I had one retired physician who said, well, he was a former department head of medicine, and he said, well, I'd like people to know that I'm a PIP. And I said, well, that's a little cryptic. What exactly does it mean? He said, PIP, previously important person. Other people have said, I'm a survival of the residential school system. Mm-hmm. It just goes on and on. But the point is, people tell you things that are really speaking to their essence. Mm-hmm. And they're the kinds of things that you can't unsee, you can't unhear. And that is what we want to happen. We want you as a healthcare provider. The expectation is we as healthcare providers should be able to see whole persons. And by the way, we give a lot of lip service to the idea that we are committed to person-centered care. And what I say is that if you don't know the person, if you don't even know a critical element of who this person is, mm-hmm. I don't know what you're doing, but you're not doing person-centered care. It's mm-hmm. just not possible. Mm-hmm. You may be doing polite care or kind care, but you can't do person-centered care in the absence of knowing who the person is. Which also, by the way, and this maybe is a segue to something else we can talk about, which is suffering. In order to attend to suffering, and when we think about compassion is understanding the suffering of another person and being responsive to it. So again, to provide care that is compassionate and is going to be effective in the face of suffering, personhood needs to be on our clinical radar.
Yes.
Appearance appears in your writing, and I think we're sort of brushing up against that, but how I appear to others is important, and I think that's the personhood. And that's a great philosophy in which to engage with anyone in this work. I think from our point of view, we often hear from people who are not being approached with their personhood front and center, and they feel very much treated as a tumor or a liver, let's say, or a breast. What can a person do when they find themselves in that place where they've waited this long for this consultation? Let's say they get 2 minutes with somebody who comes in the room, doesn't even sit down, and then they're gone. And then they feel like, well, what just happened?
And unfortunately, you've described kind of a dynamic that is too often part of the dynamic of medicine, especially, medicine that is very busy and becomes very routinized. And I just want to take you back to something you said. Say it's a good philosophy, and I would say, well, I'm not a philosopher. I'm a clinician scientist. So this idea about appearance and personhood isn't something that was dreamt up one day. We did studies, we measured various different things using standardized measures. It turns out, and again, this is kind of it sounds, the opposite of kind of flowery philosophical dialogue. We did regression models looking at all of the various measures, and it turns out that appearance accounted for the most variance when it came to predicting dignity.
Yeah.
So I say this is not I mean, if this were just sort of my ideas or my philosophy, you'd say, well, so what? I mean, everybody comes at it with a different idea, and, so why should we pay attention to your ideas? I say, well, don't, but pay attention to the data. The data tells us, and that's why, for me, this was an epiphany. The data says that the thing most predictive of patient dignity is not about what you do to the patient or what you say to the patient. The data says that the most important thing that influences their sense of dignity is their experience of how you see them. Mm-hmm. Well, now, isn't that a mind blower? I mean, so much so that, I wrote actually a separate article from the Lancet paper that published the first big findings on, predictors of dignity. That was called Dignity in the Eye of the Beholder. It was in the Journal of Clinical Oncology. And there, even though it's data-based, the metaphor that I use there is to say patients are looking for a reflection in the eye of the healthcare provider that will provide affirmation of personhood or affirmation of their sense of dignity. And you just described it perfectly, that if a person looks in your eye and all they see is the tumor or the differential diagnosis or the problem checklist, then they feel that personhood has been eclipsed by patienthood. And what's the problem with that? Well, people find it abrasive. And they also are less likely to be disclosing of what's really going on. They're going to be less trusting. There's going to be heightened discordance in goals of care. I also say on the other side of the ledger to healthcare providers and administrators, if you don't adhere to this kind of approach, you're going to sacrifice reputational capital.
Yes.
The reason that people are going to complain to your organizational oversight body is not because of medical misadventure. That occurs very rarely. The reason that people complain is they feel that they weren't seen. They feel that they weren't acknowledged. So I think that, when people say, well, there's not enough time, we really can't afford to do this, I say, well, can you really afford not to do it? I mean, do you want to spend your time dealing with complaints? Do you want to spend your time with litigation? And post-COVID, and here's another important finding, we found that healthcare providers who avail themselves of this personhood information reported heightened job satisfaction.
Yes.
So what that says to me is that practicing in this way is going to keep healthcare professionals healthier, as opposed to what you see happening in burnout literature, which is people become disengaged from, the pathos of what's happening. And, like I think an example I gave in, I don't think it was the Dignity Therapy, but my more recent book, I gave this example in Dignity in Care of a nephrology nurse who was at it for so long that she, with no pride, said, after so many years, you begin to see people like kidneys on legs. Mm-hmm. And she knew that that's not good for patients. That's not good for their families because it reduces their loved one to a set of kidneys on legs. But she also knew it wasn't good for her, that she was becoming much more disengaged, much more robotic, and I would say at heightened risk of burnout. So those are the arguments that I use for, on the healthcare side of the ledger, to say, this kind of work matters. It's important that we do this work, not just because it's the right thing to do or the nice thing to do. We do this work because it is going to be the most effective way of providing excellent person-centered care.
I think that I remember reading somewhere where if the doctor or the healthcare professional actually sits down with the person, they report that conversation was on average sort of 5 times longer than it actually was. I mean, so that's not a very difficult thing to do, to sit down, right?
It's difficult if you're a person who is worried about what might happen at the bedside if I sit down. Mm-hmm. What conversations might I be drawn into if I sit down? And that gets into a whole other area of, what expectations do we have of ourselves as healthcare providers? And are we only willing to enter into conversations when we feel that we have the answer? in our hand, we have the answer available. Because even though, I mean, the reason most of us go into medicine or went into medicine is, to be able to learn how to examine people so we can make a diagnosis of what's going on with them and then fix them. I mean, it's a fantastic kind of framework when you think about it, but it's not real life. I mean, it's real life when you're treating a pneumonia. It's real life when you're setting a broken limb. You know how to fix it, and the person will recover and get back on their way. But in real life and in medicine, I mean, there is so much of what we see. I mean, probably the vast majority of what we see in general practice are things that they can't be fixed. I mean, so it's a matter of how do we enter into that kind of work. And that led to an article that we may want to spend some time talking about called Intensive Caring, reminding patients they matter.
So you've been in this work a long time, 20 years, I think since. What are you noticing changing? Are you hopeful? I guess my point is that are we investing in the medical training, for instance, of physicians with this personhood approach? Are you hopeful for the future?
Well, I think, I'm an optimistic person. And so, maybe I see hope where others might not. But certainly just if I look at the work over the course of the last 30 years, and even in the last decade, how that work seems to be taking hold in ways that I never anticipated, that gives me hope. I began, doing dignity therapy, for example, about 20 years ago. Well, now, dignity therapy you will find in every palliative care textbook anywhere on the planet. I mean, most people in palliative care worldwide at least are familiar with that. I mean, it's a pretty simplistic approach, perhaps, to think that we just need to ask people about who they are as people. But that particular approach, the patient dignity question, has now been translated into over 20 languages. I did studies of several hundred. There have now been studies of several thousands of patients who've been approached in that way. I've been approached by many physicians, both in palliative care and more recently in oncology, who are saying this is becoming part of standard practice. I mean, it's sort of a way of engaging with people. And my hope is, and I think this is, sort of the motivation for the last book I wrote on dignity and care, the human side of medicine. My hope is that we can kind of, jump the palliative care oncology barrier into other areas of healthcare. Mm-hmm. And I'm beginning to see that happen. Later this month, I'm actually the keynote speaker for a large gathering of dentists who are interested in knowing about person-centered care. So when I see those kinds of things happening, it gives me hope. The other thing is that, in some ways, maybe it was bound to happen when you think about kind of the baby boomers and the movement away from kind of more paternalistic medicine, kind of this idea that, we're just not passive consumers. We want to be seen, we want to be known, we want to have agency. And for all of those things to happen, of course, it needs to be more than about the tumor. It needs to be about the whole person.
As I've been listening to you, Harvey, I've also been reflecting on my clinical practice where I do a lot of grief work with people after their person has died. And I'm thinking about how much, if this person-centered care has happened for their person during the dying process, how much that also impacts how the grievers process the death. So in other words, when they feel like we had a physician who really cared about my father or my wife, and I felt like she was really known and she had good care, it makes a big difference in how they process the initial stages of their grief, which is really often, their the intrusive thoughts and memories around the actual dying process and the death.
No, I couldn't agree with you more. I mean, what we have found over the years, in being very close to this work, are that all of the things that we do and try and promote to enhance the dignity of the patient are things that will uphold and enhance the dignity of the family member. So, not recognizing mother as mother is not only difficult for that female patient, but it's difficult for all of the people who know and love and see that individual as mother, because they know who she is and what her life means and what she's about. When somebody walks in the room and is blind to that, can't see that, it is an assault on everyone in that room, patient and family alike. The other thing is that when that kind of acknowledgement happens, families feel that person is being seen, and it helps them to follow what I've kind of talked about as following a path of least regret. Mm-hmm. They know that as they followed that path of least regret, that one of the things that didn't happen is mother wasn't treated in a way in which her essence somehow no longer really mattered, was no longer on the radar. The other interesting thing, and again, it's now that I've been doing dignity therapy and it's been in the literature for so long, as I say, over time, you see how things evolve. There have now been some studies that have looked at posthumous applications of dignity therapy. In other words, can we engage families who've had a death and gather them together to create a document that captures kind of the essence of who this individual was? It's almost sort of like creating this lasting memorial. And we know if you do a lot of work with people who are bereft, sometimes, grief has very poorly defined borders and people don't know what to do with their grief. This idea of posthumous dignity therapy, giving them a place where they can focus that grief and they can place that grief in a way that is meaningful and, again, will be transcendent of that person's life.
I found as you're saying that, I'm vigorously nodding my head, and I'm thinking about how I saw some very creative ways that was done through COVID. I also saw lots of places where it wasn't, and where there was this kind of abyss of that, but where families were able to gather online or find these ways to connect with that after the death.
So it's interesting. I mean, for some reason, and I don't know that I have the exact answer, but for some reason, I had more referrals for dignity therapy during COVID, which I did all virtually, than I have ever had before or since. The other thing is that we also did a study of the patient dignity question during COVID with family members whose loved ones were either unconscious or on ventilators in our intensive care unit. It was extraordinary. I mean, I remember family members at the other end of the phone who were crying when they came to the realization that this telephone call is not about finding out another medical parameter of this person who is at high risk of death. I'm trying to find out, who is this person? Mm-hmm.
Mm-hmm. As we begin to wind down our time together today, Harvey, what haven't we mentioned or spoken about that we would be neglectful to not have given a bit of space to?
Well, I think I mentioned that there was an article I published about a year ago in the Journal of Clinical Oncology called Intensive Caring, mm-hmm. Reminding Patients They Matter. Mm-hmm. And then there was a companion piece that came out in the Journal of Palliative Medicine called Intensive Caring, Reminding Families They Matter. Mm-hmm. So I would say that, for listeners who are interested, the article on intensive caring has been fascinating. I mean, it's been downloaded about 1,000 times a month since it came out. And I think it offers, I would suggest, a new paradigm or a paradigm shift that allows people to enter into this work where suffering is challenging. And it was sort of inspired by the work of Dame Cicely Saunders, who said, you matter because you are you. Mm-hmm. What I began wondering about when I wrote the article is, well, how do we invoke a kind of care that helps people to feel like they matter when, again, towards end of life, I mean, we see people who feel helpless and hopeless and worthless, and that time turns into a time of just waiting for death. It's very easy for that kind of nihilism to become infectious and contaminate families and healthcare providers. So intensive caring provides, I think, an empirically informed framework that allows people to address issues of suffering in a way that they will feel, I hope, better armed, better equipped, and at the end of the day, better effective and attentive to patients and families.
I was just struck by one of the comments you made earlier. It says, if dignity is worth dying for, it's worth studying, right? And how has the word dignity, in your period of time that you've been studying this, has the word dignity and our interpretation of what is dignity changed over the last 20 years? And I should say I started asking that in the context of sometimes it can feel like the term dignity has been usurped here and there to say there's only one death that's dignified, or there's only one way, that dignity comes into the question.
Robert Twycross was one of the great pioneers in palliative medicine. He worked hand in hand with Dame Cicely Saunders. He's top of mind because he just died a couple of weeks ago. But one of the things that Robert Twycross, he had grave concerns about palliative care that would be inclusive of assisted dying. And certainly in the UK right now, they are deliberating how to manage that. Twycross, by the way, was a palliative care physician who did some of the seminal studies in pain management early on, really changed the field. And one of the things, and this gets back to your questions, one of the things that he said is that no matter what happens, no act of legislation should contain the word dignity, because dignity is much broader and implicates many, many more things than just access to a lethal injection. Certainly, if you go to the model of dignity, and again, I didn't do any of this with any political axe to grind, but the model of dignity, hopefully in some ways, kind of reclaims the term, at least to the extent that it says, if you want to understand human dignity in the face of advanced illness, these are the domains of influence that you need to be attentive to. Mm-hmm. And so when people try and kind of use it in a philosophical or political way, I say, well, as physicians, that's not our expertise, that's not our lane. So let's look at the data to try and understand clinically what are the things that can uphold or undermine dignity. And just as, the encouragement came from that study years ago to say, if we can study it, my supposition is we can do perhaps better quality palliative care. And I continue to hold that position. I think that even now, I've got a doctoral student who's actually studying patients who have made requests for medical assistance in dying. And what we're trying to understand is the why. What moves you along this pathway? And the responses you get from people are fascinating. And they're not only intellectually fascinating, but I would say they're clinically relevant. We need to know how to respond to that. Desire for death, the wish to no longer go on living when life gets really bad, is not something that came on the horizons in 2016. It's part of the human condition. Mm-hmm. So we in healthcare are committed to understanding the human condition. Mm-hmm. We need to understand what moves people in that way so we can be as attentive and as effective as healthcare providers, as healers as possible.
This has been such a rich conversation, and I'm sitting here just thinking what a privilege it has been to be part of an environment, and call it work. It was work, but it felt so meaningful and fulfilling to be with people and to focus on this aspect of their personhood. Mm-hmm. Yeah. And you have just helped to remind us, and me particularly, of the wonderful gift and privilege it's been to have been with people in a very real, powerful way, not because of what I can give, but because of what we can hear and be listened to and affirm and be part of in their journey. So thank you.
Mm-hmm. Thank you. I've enjoyed this conversation.
Thank you for listening to What Now? On the Threshold of Life, Death, and Grief. What Now is produced in partnership with Hospice Peterborough, dedicated to providing compassionate care and support to individuals and families facing life-limiting illness and loss. What Now is recorded at Thin Spaces Studio in Peterborough, Ontario. Special thanks to Paradise Garage for providing the music. Technical support is provided by Sean Heichert and audio engineering by Kevin Fleming. More episodes of What Now are available for free on most major podcast platforms. If you found value in our conversations, please support us by following, leaving a 5-star review, and sharing with your friends and loved ones. If you'd like to support the essential work of Hospice Peterborough, please consider visiting hospicepeterborough.org/donate. Your contribution helps us to continue to provide vital care and support. Until next time, may you find peace and comfort on your journey.